Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College. Today we're going to learn about kidney stones. What are they? What causes them? And how they can be treated. My guest today is Dr. Jared Winoker, the Director, Center for Kidney Stone Disease at Lenox Hill Hospital, part of Northwell Health. Dr. Winoker, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you so much for having me.
So tell me a little bit about yourself and why you chose this portion of health.
Absolutely. I think urology, frankly, is just one of those fields that most people don't really know what a urologist does unless you happen to see one or have a loved one that sees them. And just briefly for our listeners, a urologist is someone who surgically treats the kidneys and any of the urinary organs like the bladder and even some of the reproductive organs like the prostate for men. And so one of the most common afflictions we see in the world is kidney stones, and this is where I've chosen to focus my expertise. It's just a disease process that's so prevalent and affects so many people. And when it does, it causes significant pain and problems, and it gives me an opportunity to make a big difference on the quality of life, on how someone's feeling very quickly.
So tell me, what are kidney stones?
A kidney stone is really just truly a rock, a concretion of some of the compounds that are normally dissolved in your urine. And, for reasons we can get into shortly, they precipitate or come out of the dissolved state and form actually into a little rock that sits up in the urinary system. And they can sit there unbeknownst to you, growing until that fateful day comes where they may move and block the drainage of the urinary system, specifically block the drainage of the kidney. And that leads to a lot of the, some of the infamous symptoms like pain and other things like infection as well.
So when we're thinking about stones, do they actually look like stones?
They do. Yes. We're not getting too complex here with the medical terminology. Right. They truly are rocks. Even when I have some patients who are actively trying to pass a stone without a procedure, and they often ask me what to look for. I have some samples in the office where they can see and inside little containers, and I'll tell them sometimes you'll actually hear it hit the toilet. That's how you know you passed it. So they really are actual rocks, and therefore once they form, with rare exceptions, they're there.
So what do these stones comprise of?
Yeah, the majority of the stones are made out of calcium, along with a mixture of other things. So I would say about 75% of them are composed of calcium. There are some other subtypes that we see less frequently. Uric acid is one of these things that people may have heard of, which can be related to diet, other medical problems. And then there are some rarer types in the setting of bad infections. But by far and large, most people were talking about calcium.
So when you are, as a urologist, you get these stones, is it important to know what they're comprised of? Does that help you in terms of diagnosing them or knowing what the patient has taken or not taken or eaten and not eaten? Yeah,
it's a great question because it's one of those frequent questions that a patient will ask me, like, how important is it for me to catch the stone if I pass it? Or in the event that I need to do a surgical procedure to remove their stones, they're often very eager to be like, oh, be sure to get some of it and send it off. And we try to in our power. It's not always, without getting too technical, it's not always feasible to get the stone because sometimes we're just destroying it into just dust. Mm-hmm. So it's really not as important with respect to stone prevention as people might think. It's a useful tool for sure. And if we have it, it's great. We can sometimes tell just based surgically and on the CAT scan of the most likely composition. But the reality is that most are made of calcium. And when we're sending these for analyses, we're kind of getting into the nitty-gritty of the subtype of calcium. But ultimately, it's the urine parameters that we do with special urine testing outside of the setting of an acute stone that's really going to tell us more about what we need to do for you to prevent them.
So tell me, what causes these stones to precipitate?
There's certainly an imbalance going on in the urine. The body is designed to not have stones. So there are, unmeasurable compounds and proteins in the urine that are there to try and prevent the stones from forming, to prevent the calcium from sticking to each other and forming the rocks. Of course, we don't, like most things in medicine, we don't always know the exact reason why, and we just know the risk factors that will promote it. And we just know that certain people are predisposed. In those cases, things like chronic dehydration is a major risk factor, regardless of whatever your stone is made out of. The more concentrated your urine is, that is, the less dilute. And by drinking less, all of those compounds that could potentially grow into stones, they're going to be more concentrated and therefore more likely to come out of solution. There are certain dietary things, high salt diets, lots of processed foods, low fruits and vegetables, basically not eating well can also further promote it. And then there's a variety of medical conditions, notably diabetes, overweight, obesity, gout, and things like that can certainly change urine parameters that will promote and favor the growth of stones.
So when you're thinking about stones, or the audience is listening to this and they're saying stones, are stones different sizes, different shapes, and how does that impact them passing?
They certainly come in all different sizes and shapes. Generally speaking, the larger the stone is, the harder it is going to be to pass the stone. It's an important distinction to know that a stone sitting up in the kidney, for the most part, is not a problem in and of that moment. But certainly the larger the stone is, and they essentially start from crystals that are microscopic and then over time sitting in the kidney and surrounded in that milieu of the urine that promotes stone growth, they will grow, and generally we're talking sizes on the order of millimeters, which I know sounds small, but the anatomy within which they're located is on that order also, and that's why they're problematic, and they can get up into centimeters. In general, when you're passing a stone, you're generally going to be told it's somewhere in the range of between 1 and 10 millimeters are the most common size ranges. And certainly as the diameter of the stone goes up, the ability to successfully pass it is going to go down. And we do have people who have multiple stones, and some stones on the orders of centimeters. And then there are people whose stones will grow so rapidly that they'll almost form a cast and completely fill the inside of a kidney. And we call that a staghorn stone, because if you were to actually look at the stone, it actually has the shape of a stag's horn. So they can be quite large, and that will impact how we counsel patients and what we do ultimately surgically or from a surveillance perspective.
When you're talking about these stones, can you explain to me how you identify that they're there outside of the patient complaining of pain?
Sure. So I appreciate you removing that obvious one of the pain, where it's going to lead to seeking some form of care, whether in an emergency room setting or in your doctor's office. Sometimes they are insidious in that you don't know they're sitting up in there until they present with that symptom. And obviously pain is the well-known one, but certainly other things can be an infection, like fevers that are not explained by something else, blood in the urine, things like that, recurrent urinary infections at times, something that's just not right, that's going to promote some medical provider to get some form of imaging of the kidneys, be it an ultrasound or a CT scan, along those regards.
So where's the pain? What do we use?
So the pain actually from a stone is from the blockage of urine. So, the spiel I often give to my patients, particularly for those who come to me who were found incidentally to have a kidney stone, they were getting a CAT scan for something wrong with their intestine, and the doctor told them, oh, you have these stones sitting in there. And I'm trying to explain to them why they're not the source of their pain. The kidney can very broadly be thought of as two parts. There's the solid part of the kidney where all the blood is flowing through, that does all the cleaning the blood and managing your blood pressure that we know. And then if you were to cut it down the middle, the hollow center, or what we call the collecting system, well, that's where all the waste is collecting as urine. And then it drains down a little tube called the ureter into the bladder, where you store it until you go to the bathroom. And it's really just a plumbing system. The stones, if they're not blocking the flow of anything, you can't feel them. You don't really have the nerves that line the inside to feel it. just like you can't really feel your food going through, your esophagus and your stomach and intestine, but you do feel something when it's not moving well and when it's backed up. So the pain comes from a stone that's fallen out of the kidney and is now blocking the ureter and going down slowly or is lodged there. And urine is still coming because the kidney is always cleaning the blood and always on like a faucet. But the buildup of pressure behind that stone and the stretching of all the structures upstream is what leads to that severe pain that it doesn't matter what position you're lying in on the bed, you just can't find a position to help relieve the pain.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about kidney stones. What are they, what causes them, and how they can be treated. My guest today is Dr. Jared Winoker, the Director, Center for Kidney Stone Disease at Lenox Hill Hospital, part of Northwell Health. So you mentioned the stone going through the ureter. Is there ever a time when the ureter is damaged or structures are damaged as that stone passes through? And what typically would happen when that occurs?
The stone itself, more often than not, if it's going to make it its whole way through, generally will not cause any long-term damage. Obviously, there'll be some inflammation and swelling, but the body is very resilient and it heals well. But with people who have recurrent stones, meaning they form stones over and over and they've passed many in their life, maybe perhaps they've had some surgical procedures, which introduces more risk of inflammation and scar tissue. They can certainly be at a slightly higher risk than most people of developing a narrowing of the ureter, of scar tissue, which we call a stricture. And strictures can be problematic because, for one, they're going to limit the passage of subsequent stones, because the rule of thumb is that if you're a stone former, you're a stone former, and there's likely going to be more to come. But it'll also complicate any future procedures you may need. It may limit the ability to introduce scopes and other little instruments we use to get up into the kidney to treat it. And really the most feared complication of having a stricture is that if it's narrow enough and the tubing is that tight that urine just can't drain, now you have a backup of pressure and obstruction of the kidney. And over time, you could develop a serious infection, or you could even lose your kidney. And that's not to scare people into saying that any kidney stone you got to remove it, because these are more the exceptions than the rule. So they're not very common, but they are known to occur.
So talk to me about the treatment. How do we treat stones?
So broadly, we'll think of treatment as far as some form of observation, whether it's surveillance of known stones that are just hanging out in your kidney versus watching someone who's passing a stone closely with close follow-up over the span of a few weeks to make sure they successfully do so. So that's the side of non-surgical intervention. And then if we're going for a treatment, there's really, for the most part, three ways we go about this. There's the classic shockwave lithotripsy, which is what some people, the old adage is just to call it lithotripsy, which is essentially aiming sound waves at the stone in the body under X-ray and relying on those very focused sound waves to break up the stone into smaller pieces such that the natural flow of urine would pass them out. And that's classically a procedure done under some sedation or anesthesia. The most common procedure, probably 80% of all kidney stone treatments in the U.S., is a procedure called a ureteroscopy. So if anyone on this listening probably is familiar with what a colonoscopy is, so it's very similar that instead of a camera going into the GI system, we're just going into the plumbing of the urinary system with a really tiny camera, a few millimeters big, going up the urethra and up into the kidney to wherever the stone is located. And there we can break it into smaller pieces to remove it using a very small laser. And then the third procedure, which is the largest of these minimally invasive treatments, has a long name. So we call it a PCNL, which stands for a percutaneous nephrolithotomy. I don't expect anyone to remember that. But essentially, the stone is so big, or perhaps there's some complex anatomy that prevents us from attacking it from just going up the natural urinary system. We actually go directly through the back. So that's where the percutaneous comes in. We go through the skin with a needle into the center of the kidney, and then we're able to introduce our slightly larger camera into there, break up the stone, and remove them all.
So which of these procedures are most commonly done?
So it's going to be the scope. The ureteroscopy is going to be that. We have an abundance of riches in surgical technology these days with the power of the optics of our cameras and also the very small size of the chips that allow us to introduce very, very small instruments on the size of a couple of millimeters in diameter with very strong lasers that are very safe in the kidney, but they work really well against the stone. And that really allows us to tackle a myriad of stones, both in terms of complexity and size. But with any of these treatments, and the way I described them was in terms of increasing invasiveness, that comes at the trade-off of surgical success. And by surgical success, we're characteristically talking about the ability to render you completely stone-free after a procedure. It's not always possible, especially with larger stone sizes, and that's where we counsel patients exhaustively to understand the trade-offs of the invasiveness of the procedure versus what are our goals. Is it to get your stones completely out, or perhaps it's just to significantly lower the risk of not being able to pass a stone if it should move, or to remove a blockage, things like that.
So tell me, how does age tie into kidney stones? Do you find that more the older adult have stones more than the
Not
younger?
so much, actually. It's one of those things when people know I'm a urologist, they assume I see older patients and particularly men. There's maybe a hair of a preponderance of stones in men versus women, but that gap is really closed. And really, kidney stones can pop up at any age. I would say that there is always a strong family link, whether it's genetics or similar dietary habits that are learned that are promoting those stones. But, I have patients ranging from, teenagers to in their 90s and 100s. And perhaps at some point in your life, you may have one stone and then go 50 years. And then there are people who have a pattern where they form one every year starting in their 20s. So it's really a large catch. We catch all ages with this.
So when you know you're predisposed to stones or you're trying to prevent stone formation, what would be some of the things that you are telling and teaching the patient?
As far as general recommendations, fortunately, many of these things align with just general health and wellness, so we're not recreating the wheel here. Fluids are by far the number one. My patients and colleagues often joke that I'll tell them it's number 1, 2, and 3. Because the better hydrated you are, and by better hydrated, I'm talking about the more dilute your urine is, as close as it gets to clear, that very faint yellow, I'll tell patients, that's kind of where you want it to live. People want a number. How many cups of water should I drink a day? We like to aim for 2 to 2.5 liters. But in reality, I care more about the urine output. So in a warmer month, you need to be drinking that much more to keep your urine coming and keep it very, very faint. That's by far the most important thing for all stone formers. Can't give those compounds an opportunity to form solids and become stones. Moderating your salt intake. I know you've had some wonderful cardiology guests in the past who harp on, there's just a chronic overconsumption of sodium in our society, and I think the average American probably consumes at least double the recommended daily allowance, which is only a teaspoon. Salt is an interesting thing. Other than its blood pressure effects, salt will actually drive calcium into your urine. Most people think, I form kidney stones, I know they're made of calcium, I need to avoid calcium, and that's actually the wrong way to go. It's paradoxical, but a low calcium diet can actually harm you and form stones. You want to just eat normal calcium, which most of my patients ask what that is. And I say, whatever you're doing is probably fine, right, even if you're taking supplements. The high salt in the diet, the body tries to clear it. So you end up with too much calcium in your urine as a response to the kidneys. And then increasing fruits and vegetables has a lot of what's called citrate in them, especially those citrus fruits. And citrate is a derivative of citric acid. And citrate is probably the most important natural inhibitor in your urine and your body for preventing stones. And the one caveat I'll say to that is being cautious with things like spinach, which many people, if they go online and look, they'll see that spinach is a food that has high of a compound called oxalate, which can promote stones.
Wow. So what is this about the cranberry juice and acidifying the urine? What are your thoughts?
Yeah, so cranberry juice, a lot of the data and the research comes out on that is particularly with regards to recurrent urinary infections. And generally we're talking about the cranberry extract, not the cranberry cocktail that a lot of patients
Right.
think, oh, it's easy to consume. But there is great data on preventing recurrent infections. Now, obviously, recurrent infections can be linked to stones. So transitively, we can certainly get there. But there's not like a great wealth of data that tells us cranberry extract, even in the correct formulation, is really great for stone prevention, unless you are one of the few whose stones are driven by recurrent infections.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about kidney stones. What are they, what causes them, and how they can be treated. My guest today is Dr. Jared Winoker, the Director, Center for Kidney Stone Disease at Lenox Hill Hospital, part of Northwell Health. How do you really decide? I know that you talked about surgical intervention or treatment intervention, but tell me about the medications that you may prescribe a patient that have stones.
One of the most important medications we give is really a supplement, which is a citrate supplement. So on the heels of what we just discussed about how important citrate is at preventing stones, it binds to calcium so that they can't bind to itself and grow. We will often give a supplement called potassium citrate, which allows us to deliver very high doses of citrate such that we can supplement whatever you have, or what we frequently find is that people have chronically low levels in their urine, and that may be driving their stones. Alternatively, we sometimes make use of medications called thiazides, which our patients, many of them are probably on. It's a form of a water pill for high blood pressure. And what we're doing is we're taking advantage of the fact that that medication in the kidney causes some changes that actually allow the kidney to reabsorb the calcium, to get the calcium out of the urine. So in that way, we're lowering the calcium that's in the urine. You combine that with things like citrate, which are inhibitors. So we're kind of hitting the risk levels on both ends. And those are the predominant medications we're talking about. Of course, there are the less common types of stones, like the uric acid ones I alluded to, where sometimes we have to be adding medications like certain gout medications to help lower the total level of uric acid dissolved in the urine.
Tell me, if someone suspects that they have a kidney stone, just listening to this interview, what would you say they should do?
Well, certainly if it's not a suspicion based on a terrible pain. Of course, if you're having that terrible, awful pain, I'm hoping you're knowing to go to the emergency room to be evaluated. But, if you've been having like a lingering flank pain or something in the kidney, it's probably best to at least speak with, if not a urologist, even your primary care doctor, who can at least initiate the evaluation, which would probably be something as simple as an ultrasound and or an X-ray. Jumping into something like a CAT scan may ultimately be needed. But for someone who may not have a risk of stones, or at least not know they have prior stones, it may be most appropriate to start with one of those less invasive forms of imaging.
So you mentioned that you are a urologist. How does your role differ from a nephrologist?
I like to work in analogies, in that what I'll often explain is just how a gastroenterologist is kind of more the medical side of the digestive system, whereas a colorectal surgeon is more the surgical side, and then there's certainly overlap. That's kind of how I would liken a nephrologist being more the medical management of the kidneys, whereas the urologist is the surgical side of the kidneys, whereas we also will manage some of the medical and surgical issues of the rest of the urinary system, as well as the male reproductive system.
So are there any stories that you could share with us about a patient that you treated recently with kidney stones? Yeah,
I mean, countless. There's certainly a great one recently who had a very, very large stone, a healthy 50-something-year-old woman. Large stones. I mean, it's on the order of what we talked about before, those staghorn stones, where they're really growing into these very large sizes. I mean, to be able to tackle them endoscopically with the little laser would be kind of scratching away a boulder with a toothpick, and something that I would counsel a patient would normally take about maybe 2, 3, 4 times going in on different days under anesthesia to try and render her anywhere near free of stone. And she was very very appropriately, but a little bit nervous about having something a little bit more invasive, like the poke in the back. So we were looking for alternatives, and we're fortunate, not only at Lenox Hill, but at Northwell Health, that we have some very new advanced scopes that actually have a suction element to them. So this is brand new in our field, which is undergoing a lot of like great technological advancement right now. And so we were able to laser down the stone into complete dust over a span of about 45 minutes of lasering. And normally I would have to rely on her to try and let the urine flow to pass that, wherein, those stone fragments may get stuck, cause pain, cause infection, come back from multiple procedures. We were able to use this new device, this new form of a camera to really clean her out completely under direct vision, suction out all that debris. And, we got a CAT scan afterwards, which showed that after one trip, under about 2 hours under anesthesia, she was completely stone free with a less invasive treatment than she would have otherwise had. So she was, she's the, the poster child of how well some of this new technology is working for us. So we're fortunate to have that available. And I'm sure it's only a matter of time before that's a more of a widely available technology across the country.
Yeah, more of a standard of care. Is that the CVAC that you were describing?
Yes, correct.
And
CVAC device.
What does that acronym stand for? CVAC.
So I've spoken with the company about this. It's actually not even an acronym. They somehow it's multiple iterations of working off the device of the fact that there's a vacuum element to it, and they were backing into a nifty name for it, and somehow it's just taken on this new version and spelling that it actually doesn't even stand for anything. Okay. Believe it or not. But I'm sure someone will come up with what we call like a backronym to kind of create like a nice name after the fact. Yeah.
So that's great. So if you had to give me just two words, for those that may anticipate or may have experienced or maybe you prevent kidney stones, what would you say?
Fluids is always going to be my first one because, we're, as urologists, we're surgeons at heart. And certainly we enjoy what we do in operating, but I'm all for prevention and staying out of the operating room. So fluids is one, and I guess if you're going to do another one, it's I may have to extend it to more than one extra word, which is just seek care. If there's something that doesn't feel right, you're not sure, you just want more information. There's nothing wrong with a doctor's visit just to learn more. Seek some care.
Well, I'm going to go drink my fluids. That's what I'm going to do right now. So thank you for being here, Dr. Jared Winoker, the Director, Center for Kidney Stone Disease at Lenox Hill Hospital, part of Northwell. We thank you for giving us this very important information, and we hope you continue to stay healthy yourself and keep doing the great work you're doing. And I'm seeing that you had a girl. Is that
That's right, you? I did.
Congratulations on your little girl.
Thank you very much. I appreciate the time today.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.